Lawrence campus. Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. We're broadcasting live from the Dolph Simons Family Studio. Appreciate that you're back with us today. I think we have a fascinating program. But first, I'm going to turn to Hawkeye and say, Hawk, how are the numbers this morning?
They're good. They're pretty good. You know, I think maybe we are reaching into this equilibrium that we're talking about in this constant state. Always we want less cases in the hospital as we can, but today is 23 in the hospital. 10 of those are in the ICU and 3 are on the vent. In addition, we do have those 30 patients that have met our gone past the acute stage and are in the convalescent stage, and so they're not recovered, but they are past that acute counting as far as our numbers.
All right, so some happiness, but it's a little bit of a, we're at that little kind of crest, and we're a little nervous about what's going to happen, especially if society begins to open more around education, which is coming right up, and things of that nature. It looks like around the United States, areas that have had stronger mask wearing and social distancing are clearly doing better on their curves.
Yeah, absolutely. We know those mask mandates work in addition to the other interventions such as the distancing and the small group gatherings, no large group gatherings. And if you look on kansascity.com, we can see that overall the 7-day running average is lower than it was at the end of July. So that's a very good thing. We did have over 600 cases, I believe, that were documented on Saturday, but since that, the new cases per day for the last couple days, whether that's just a delay in the results, but I think it looks pretty good overall as far as the overall running 7-day average in the Kansas City community.
Yeah, amazing stuff. So, many people are facing chronic health challenges, especially during a pandemic. We're going to meet one of those people here in just a moment. And because we're also going to meet one of our doctors and others who have participated in what is a remarkable story about how life goes on even during COVID-19 and in the midst of the pandemic. Carol Barnett recently turned 61, and she got the ultimate gift of life during this pandemic, the ultimate gift of life. Let's take a look at her video.
Carol Barnett is a wife and grandmother, world traveler, and very active in her community, and can now add heart transplant recipient to her many titles. 30 years ago, Carol was diagnosed with arrhythmic right ventricular dysplasia. 6 years ago, she was told she'd eventually need a new heart. She never thought that time would come during a worldwide pandemic.
All of a sudden, this became very real to me.
Her cardiologist at the University of Kansas Health System said it needed to happen now.
My heart was too weak and I couldn't leave the hospital till I received a new heart.
That was April.
I received the call on May 7th, which happened to be my 61st birthday. Best birthday present ever. I received my heart on May 8th. I felt my heart and I said, oh my gosh, this is me.
But Carol, who's used to lots of family around, had to tackle this challenge on her own.
There were certain moments I would, of course, love to have them there, but I knew that wasn't possible.
Carol wasn't allowed to have visitors due to strict hospital policies, but says she felt safe here and had no fear of COVID.
That was never a concern of mine, really, ever.
Now, 3 months out from her transplant, Carol looks forward to more trips like these.
We went to Antarctica, and I did the polar plunge.
But for now, it's a simple walk for this avid runner that reminds Carol of her new gift.
I've been given this whole new lease on life. The numbers, unfortunately, of people who are dying from COVID, never mind other illnesses, they're struggling to stay alive, and I've been given a gift to extend my life.
That is a remarkable story, and it's such a remarkable time. And here in the studio with us is Matt Danter, her cardiothoracic surgeon, and in Studio B is Nick Hagelin. Nick is a cardiologist who is a transplant cardiologist who's been helping to treat Carol. So, Matt, talk to us a little bit about doing a transplant in the midst of a pandemic.
Yeah, well, there were a lot of unknowns. I think that the program made a lot of conscientious decisions to try and protect patients and people who may come in contact with potentially infected people at outside hospitals. But I think the very metered response to sort of still continue the program was able to provide life-saving care for people who desperately needed it. So that was there was never really an intention to stop the program, but we did in a very reasonable way sort of evaluate each case as it came up and as to how feasible it was. For Carol's case, there wasn't much leeway to delay things or put off her admission or these kind of things because of how critically ill she was.
So, Nick, this has to be kind of a challenging time. Tell us about special precautions that are being used. Oh, by the way, there's a picture up right now with the cool tent that some of our anesthesiology people have been doing. We talked about that yesterday. But Nick, talk to us a little bit about some of the special precautions that are in place to help patients during a pandemic who need a transplant, which is going to suppress their immune system.
I think just the basic paying attention to hand hygiene and masks are still absolutely at the forefront of what we recommend to patients. The other aspects might be doing Zoom visits or telehealth visits when necessary to try to keep patients in their home environment and prevent them from going out excessively. So that would still be the basis of our recommendations to patients either receiving or after transplant.
Yeah, big deal. Okay, Carol, first of all, I love the Transplant 74, nice KU jersey, and can I just say, even better, Star Trek behind you, Trekkie to Trekkie. Are you the Trekkie, Carol?
Well, technically, it's my husband, Tom. Good morning. But a little bird told me that you're a big Trekkie fan.
Yeah, I might be. And has your husband drug you into it like I drug my wife into being the Star Trek? Yeah.
One of our first dates, in fact, was to a Star Trek convention. So.
I can totally understand. I've been to a few of those. And so, Carol, just to say, you'll understand this, and it totally applies to you. Live long and prosper. I mean, does it get any better than that, really? Yes, indeed. Well done. Okay, Carol, how does it feel? How you doing? Now that we've talked small talk, how you doing?
I feel great. I've increased my walking to 4 to 5 miles a day, and I'm doing that 4 to 5 days a week. I'm gardening, I'm cooking, much to my husband's delight, and I'm back to taking out the trash on Monday night. So.
Wait. You take out the trash on Monday night? Would you talk to my wife? Because I have to take out the trash every Thursday night. It's one of those things that I hate. I do wash dishes, though. So Carol, tell me a little bit about what it was like. Did you have a kind of a special nervousness about, I'm sick and it's a pandemic?
Well, that was an initial thought, but at the time, I didn't realize how sick my heart was.
Right.
Because I was so active. And the way Dr. Hageland and Dr. Berenbaum explained what I was going to be doing was a proactive move. So I really didn't realize the critical situation of my heart. And when I'd been in the hospital for 2 days of the 3-day evaluation, that's when I learned that I couldn't leave the hospital. And as sad as that was for the moment that Tom and the rest of the family couldn't be there, I felt I was under such great care that in the way the nurses treated me, everybody, they were just on the front line and always were there to listen and extremely, extremely empathetic to my being there on my own.
Yeah, that has got to be a big deal, because in the pandemic, to keep patients safe, you were being treated when there was the no visitor policy here. And
right.
So that had to be a little tricky because I bet your family wanted to come see you.
Oh, yeah. And I saw Tom twice during the 3 weeks that I was at the hospital. one evening, and then the morning that I received my heart. But thankfully, there was technology, Zoom and Skype and other forms that made a huge difference, as much as we all presume these days. Yeah.
Yeah. So he was really left at home watching a lot of Star Trek reruns.
Correct.
So Nick, what was what told you that the time to act was now?
Yeah, Carol's right. I think, we spent some initial time just discussing her condition, where she stood now. And then we also spent some time discussing the risks of waiting longer. And I really think it was a very good sort of come together by all of us, and we agreed that we had to, proceed with transplant.
Yeah, that's a big one. So Matt, tell us about a little bit of the special precautions you guys are taking to keep people safe, whether it's a transplant or any form of surgery.
Right. Well, it's been an evolution, right? So initially everybody was out of the room for a period of time where we did any of the aerosolizing procedures in the room. A big difficulty with transplant is coordinating with donor sites who may have very different either approaches to their precautions than we do. So our principal goal was to protect the patient from being exposed to the potential COVID virus, and then also to protect the people who are charged with procuring this, because transplant really, even more so than a lot of conventional procedures, but they are as well, is really a team sport. So we have donor teams that are procuring from as far away as several hours away, and we have people on site. So there's a lot of interaction with care members from other hospitals. So we really tried to make sure that we used our PPE, kept our distance when we can, but it's hard to do that when you're operating on someone. So I think we took the collective experience of the people that are here, which is pretty extensive, and we decided that we weren't going to drastically modify our approach to things. And in saying that, we also have to remember that there's another team that's going, so we had to have the buy-in from all of our partners who typically procure the organs. So I think it was really sort of a team effort in terms of making the decision to proceed, because some programs did shut down, and our belief was that if we do that, this is something we're probably going to have bad outcomes of people waiting if we're not able to provide this relatively precious resource for people. So we continued the program very cautiously and used our model of PPE and social distancing and masks at the outside hospitals and within the operating rooms here to make sure that we did the best we could to protect everyone. It's always funny too, Carol, to hear that you're doing far more exercise than your heart surgeon. So it's always
you're
nice to hear.
You're a cardiologist too.
Yeah, it's always nice
Carol,
to hear.
Tell your team to get their tails in gear and go exercise. Let's go, people. You got to stay around for a while here. We need you around. Carol, lecture them next time, okay? Yeah. All right. Well, Joe, let's see if there are questions first from media. All right. So, Jill, we're up, and I bet there are some questions out there from our listening audience.
Always. All right. Cindy wants to know, Carol, you weren't afraid of COVID in the hospital. What about now?
All right, Carol, it's out there. What do you think? You got to be taking a lot of steps to help stay safe.
That's right. Well, the March 15th or so, when we went on lockdown, and before I knew I was going to go on this transplant journey, my husband and I stayed home because I knew I had a heart condition, and because of our ages, we stopped going to places. I haven't set foot in a grocery store or any restaurant, anything, since mid-March. And we just take all the precautions. We just extremely cognizant of our surroundings and the warnings that people, that you and the CDC, others have told us to do, and we're very cognizant of that. We're lucky we live somewhere where we have a nice yard and can walk around, and we just make the best of the situation.
You know, that is probably some of the best advice we've heard on the show. You just have to make the best of the situation you're in, and that's true. Even in a pandemic, you can find joy. It's not maybe the same place you got it before. Yeah. All right.
Cody with Channel 9 texted, and he wants to know, what advice would you have for someone who's anxious about going to the hospital for a non-COVID reason?
All right. So, Carol, tell us a little bit. What is your advice? And then we'll turn to Nick and Dr. Danter. We'll see what Dana says, too.
I would say if your doctor believes you should go to the hospital, you should listen to him or her. The hospital is one of the safest places you can be because, as Dr. Danner said, you're taking all the precautions you can to make the environment as safe as possible. I never felt nervous about being at KU and having the COVID exposure just because of how all the precautions they took, and I had to wear a mask anytime any person came into the room. They of course wore masks up, and sometimes they had to wear the shields, and they got all foggy. I felt sorry for them on those days, but I knew it was the right thing to do. I'd say go for your health. Your health comes first. So.
Yeah, that's good. Okay, Nick, what are you thinking? How do you tell your patients about coming in and being safe?
Yeah, there's so many policies and procedures in place, like Dr. Danter said, that the team here at KU has put into place, and so I think that's incredibly reassuring, at least for providers, making recommendations and talking to patients about sort of balancing the risks of leaving the house and coming to the hospital environment, but with an important counter of their health, just as Carol said. So it has to be a discussion between the provider and the patient, but I think that we've really have a good system and policies and procedures in place here to make that the least risk possible.
Yeah, I think, Matt, that makes total sense because you guys have worked hard to keep the operating room safe.
Yeah, I mean, I agree, and it was something in evolution as well, right? When it started, it was very different than it is now, but that was one of our concerns, surgically anyways, was that in the event that we're minimizing the number of quote-unquote elective cases that we do, there's people out there that are going to have significant disease that need to be addressed. And as things evolved to a point where we started to get our arms around the problem, I think that very sort of, again, judiciously opening up again prevented, I hope anyways, a lot of those eventualities. I think I would echo what Dr. Hagman said, which is that, you still need to not disregard common medical conditions because those are still out there, and sort of their sort of prevalence and their incidents in the community have not changed through this, so those still need to be addressed. So I think that you need to be conscientious about your approach to meeting, discussing with your physicians and providers about what the next steps are for common conditions.
And I think, Dana, we still haven't had spread from inside the hospital to a patient or vice versa around COVID.
Yeah, just as you said, Matt, we have evolved our processes, our systems that have been in place for years now. And again, it all started with emerging infectious diseases such as Ebola. Certainly when this came on, we evolved our processes. They are very good systems and processes now on the health system level. Just as you said, there hasn't been spread from patients to workers and vice versa. And we also know that that is not uncommon in the medical facilities. There's a study out of Wisconsin looking at seroprevalence, meaning they went back and tested antibodies of their workers to see who had actually had contact and come into contact with COVID, and that was much less than in the community. So certainly as there is more community spread, it gets more difficult for the individual worker, whoever that may be in the health system, to stay infection-free. But certainly we know as the health system, all of our procedures, policies, all of our systems really aim and have been very good at keeping patients as well as the healthcare workers safe.
All right, Jill.
All right, Rob wants to know, what about the donor organs? How do you test them for COVID, or do you?
Matt, what do you think? You got to be checking that out.
We did. I mean, that was part of the issue early on when the testing was, that comes with significant delays. But What many might know is that from the time you get a call about a heart transplant, you have anywhere between 8 to 36 hours before you actually move forward with things. So we were able to specifically test the donor, as well as to test the people that had been taking care of the donor at the donor site for most of our patients. There hasn't been, except perhaps in the window of time where we didn't know exactly out in the community what the prevalence of the virus was. So I'm saying before sort of December and these kind of things, we weren't specifically looking for that. But as soon as we were aware of the pandemic, we tested everybody on the sites that we were going to potentially procure from.
So Carol, I'm sorry, go ahead.
Sorry, and it's important because, one of my partners that is also one of the transplant surgeons, Dr. Abicht, actually went and procured the organ. So he, it's kind of the whole team involved with in specifically Carol's case, but in general. So our principal goal, in addition to making sure that we successfully procure the organs, is to make sure that we keep our people safe.
Carol, does it feel funny to you to have another person's heart beating in you?
So for 30 years, I had this arrhythmia, and I was just used to that weird beat. I still sometimes, at random times during the day, in the middle of the night, I'll think prednisone for that. But I just sometimes just pause and can't believe that this is me. And I don't know if weird is the word, but just surreal, and I just find it to be a miracle. I don't know if I'll ever quite be able to verbalize what this is like, other than just gratitude and all things good, how fortunate I am that I was able to even get listed to have the kind of care that I did, and to receive this young woman's heart is extremely humbling, and it makes me realize every single day, or whenever I think about it, how truly, truly lucky I am that I get to go forward.
Well, as an old physician who was involved in lung transplant for a number of years, this is the greatest thing, and I do just say to our listening audience out there, if you ever have, and hopefully you don't, but it comes, that you think about being a donor, it doesn't get any better. It is the greatest gift to give to someone, and it is the greatest gift to receive.
Lots of questions pouring in. Lex wants to know, since other programs closed, did that mean you did more heart transplants? Does it work that way?
Potentially. Now, I would say that the actual number of programs that closed was very small, and I think those were probably small programs in high infection rate places. What happened for most of the programs in the country is that we revised our travel radiuses for how far we'd procure from. We, of course, were not going to go take an organ from New York during their crisis that they were undergoing. But I think there was a conscientious decision by the team to not be that restrictive. So we did alter our radius wherein we would look for or accept potential organs. But I think there probably was some, increase in potential volume as a result of not completely restricting the organ availability. But the transplant volume has gone down somewhat, but not astronomically, and I think it was only for a very temporary period throughout the rest of the country.
We have a couple of more on-topic questions, and then some that are not.
You bet.
Leanne wants to know, did any patient turn down a heart because they didn't want to go through the heart transplant during COVID alone? Let's
talk. Nick, what do you think? Were there people turning down heart transplants because they were afraid of not be with loved ones or to have visitors?
Not to my knowledge. I think that most listed patients on the transplant list are heavily invested in knowing what their surgeon and cardiologist thinks. And I think if we truly as a program felt that we would be in such a high-risk situation that we would have to recommend a patient not accept an organ, we would tell them that. But we're not in that situation, and to my knowledge, that hasn't occurred.
Leanne wants to know, I don't know who said this one, but they want to know, did any patient get COVID and not be able to get a heart?
Do we have anybody get COVID or not get a heart, guys?
We had, to my knowledge, there was one patient who was completely asymptomatic waiting, who showed up. We tested the patient for COVID. It came back positive, and then we scrubbed the transplant for obvious reasons, and we were, to my knowledge, still able to reallocate the rest of the organs elsewhere.
Dan, did you know, because we do liver and we do kidney and bone marrow. Any other issues that you're aware of?
Not that I'm aware of. I maybe vaguely remember that. And again, this goes back to overall safety and processes. We are screening every inpatient that comes in, and I assume that's probably how this patient, or even before a procedure, we screen everybody for COVID. I'm not aware, maybe, Dr. Coomer would be aware, but I'm not aware of really any other.
Yeah, I'm not aware of any that I've known either, but that I may not have known, so, okay.
All right, and then one more heart question for right now. Quinn says that I've heard fear is bad for your heart, and I'm afraid of COVID.
Nick, is fear bad for your heart?
I would say in usual circumstances, I don't think it will have much effect, but fear is healthy from the standpoint that it can protect us in these time periods as long as it's not excessive. So that's a really difficult question to answer, but that's a response.
Carol, you were shaking your head yes, that fear is bad for your heart. Talk a little bit about how you felt that.
Well, I mean, I didn't now, but fear, I think, can be an element of stress, which, of course, is not healthy for any of your whole person itself.
Right.
So,
well, and we do know that.
I do whatever I can to minimize stress.
Oh, that is good advice. Probably not something the four of us really do very well, but no.
I don't know how you do it every day.
But we do know that chronic stress does play a role in limiting life expectancy. It's pretty clear in populations of people who do have chronic stress that it does cause a lot of health effects and may shorten life expectancy by 3-5 years and more. This kind of chronic stress syndrome, or however you want to call it. But I do, the fear and the anxiety associated with COVID, boy, it's just palpable and it's real. Unfortunately, not as real for some, especially maybe some young people who still want to go out and party and then all spread COVID into large groups. We'll talk about that tomorrow.
That's right. All right. Dr. Seitz, this is from Charlie with KSHB, Channel 41.
Hey, Charlie.
You mentioned at the beginning, some worry about reopening in schools. What advice do you have for parents of school districts which are not following the recommendations of the health departments?
Well, let's hit the hard question. So just to say, tomorrow's program will be fascinating because Dana and I will be here along with Dr. Doug Gerard, the chancellor at the University of Kansas, and we're going to talk about reopening of public education and the university. Here's what I would say about schools. I think that this is a highly personal decision. There are different decision levels that are being made. There's a decision level that occurs at the county or at the school district level, in which the school has to say, do we think it's safe to return? And then I think each parent has to make a decision about their own situation. And here are the things you got to consider. How good are the pillars of infection control within that school community? Are they able to accomplish distancing? How good is the mask policy? And how healthy are you and your family? I think that's a really important consideration. I'm going to take Carol as an example. If Carol had young kids in school, I'd say kind of dangerous for those kids to go to school and bring a potential COVID back for a heart transplant. And I'd probably say, wow, in that situation, I'd say kids probably not in school, do homeschooling, do learning online, whatever, school online. However, if you have a family of people who are all very healthy and the children may be challenged by significant problems or insecurity or mental health issues about not being at school, well, that's a different situation. So I don't think there is any absolute right or absolute wrong. I think it's a matter of deciding how important is your bubble and how healthy are the people in your bubble. And that means your physical health and your mental health, and then trying to decide how healthy the school is approaching the pillars of infection control. Are they really trying to follow mask wearing and social distancing and keeping kids apart and doing all the things you can best do, knowing that it won't be perfect? When you put a bunch of kids in school together, it ain't going to be perfect. But how hard do people work at it, or is it just kind of a free-for-all? And then you just have to put those two things together and decide, what can I do? What is, and then the third question really is, what's the background rate of infection in any given community? Because that's going to be a lot less in some areas than it is in others. So those are the things I think you have to put together. You just make the best decision that you can. Dana?
Yeah, absolutely. There was a study that was published recently out of the Annals of Internal Medicine that looked at some questionnaires from a couple years ago, and what it found was that there was a significant amount of teachers who have comorbid conditions and may be at risk for severe disease. There was a significant amount of adults living with those children that are going to the school that have comorbid conditions and at risk for severe disease. So not only are we looking at the children and the acute infection, but also what happens afterward. We are looking at the adults and what happens to acute infection and what is their risk for severe disease. As far as making that decision, certainly we know from some modeling, and again, modeling is not perfect, the best things that can be done, just like you talked about, are some of the engineering things, and really class density, and keeping as low amount of students in there in the classroom as possible is going to be the best thing for decreasing the amount of spread in the school, decreasing the amount of quarantine, because when you start having quarantine of students and teachers and substitute teachers, that gets extremely difficult. Again, that in addition to masks and some of the other engineering things that can be done. Not all school districts can do that. Not all schools can do that. So it does come down to the individual school district, and then the people inside the home and their decision and what is their risk for further complications from COVID.
I would just summarize by saying, as we get this question, we'll get it again tomorrow. And actually, Nick, I want to turn to you. First, let me turn to you, and then I want to summarize. Nick, what would you say to your patients about having their kids go to school after heart transplant?
Yeah, that's a very good question. Like you already pointed out, I would say, something very similar to what you said is that it is an individual decision, because not everybody has a patient on immunosuppression who they're living with. And I think that and some of the other risk factors that would go along with patients who receive transplants, would certainly portend a potentially higher risk if they got infection and perhaps even to get infection. And so it's highly individual. But I think a transplant patient who had young kids, I would encourage them to do everything with PPE that we all recommend already, but then, think real hard about whether they're going into a public school system or a school system in general with other children.
Carol, you have pictures of kids and grandkids, I'm going to bet, and with you. Are you able to see those wonderful kids?
Well, on on Zoom or FaceTime. Three of them live in Colorado, or two of them live in Colorado, three of them live in Philadelphia. So
they're socially distanced.
Yeah, they were here. Right, they were here during my recovery, which was probably some of the best medicine I could have received, and they all had been very careful about self-quarantining before they came to Kansas City.
Yeah. Here's the deal. If you decide to send your kids to school, that is not wrong. And it's not right. If you decide to keep them at home and have them learn it's not wrong. Learn online, it's not wrong and it's not right. It is a personal decision. And really neither the government or the school district or anyone can make that for you, given the unique circumstances that every family has to live within.
Jay has a question. He writes, there's a lot of decisions being made based on percent positivity rate, But what is the minimum percent of the population that must be tested for this data point to be meaningful?
Oh, that's a great question. That's a really insightful question, because what it's really saying to you is if you only test people who are sick, of course you have a high percentage positivity rate, which is true. If you don't do enough tests of the random population, you really have a harder time knowing, Dana.
Yeah, absolutely. You know, we have said this before. We would like to test everybody every day to really drive up the numbers of tested and hopefully drive down the percent positive. Because that will give you a better picture of the overall incidence or the prevalence of the disease at that point in time in the community, and that's what we want. And we'll have Dr. Gerard talking about this tomorrow. We were able to mass test everybody coming back to campus.
Yes.
We had talked about that earlier last week, I believe, and at that point in time we were seeing a 1% positivity. Now, again, that's a specific demographic, but that just goes to the point, if you are testing enough people, you will get a better picture. And Dr. Wild had stated before about the megapixel, the 2 megapixel picture versus the 12 megapixel picture. And we would like the 12 megapixel picture. We would like to have as many tests as possible on as many individuals as possible to really get a good number as far as percent positivity and really how many cases are out in the community. So right now there are testing capacity issues. There's the turnaround time, there's the number of kits that are available, the number of resources, the number of workforce hours that are available. So there are a lot of caveats to being able to do all that testing.
Yeah, it's interesting because if you're on a college campus, it really is a very local answer. So we tested everybody at KU who's coming back, because that's essentially a mass migration into a community. Honestly, if you're trying to make a decision about the health of that campus, you're not really going to care as much about what's the testing positivity and how many people are being tested in Kansas City. You want to know about Lawrence. So what happens is we've learned that our testing number is about 1%.
Yeah.
We'll continue to do randomized testing. If we see the overall number starting to pop up to 5 or 10%, we know we're having a problem, because we now know what it is right from the start.
Arietta wants to know, for diabetics, are there any correlations between blood sugar levels and COVID?
Oh, that is another great question. All right, Dana, what do you think?
Very second level question. Very insightful. Well, we know that people with diabetes in general are more at risk of severe disease, critical illness, and death due to COVID-19. But this is true for people with diabetes for a lot of infections.
Yeah, or any condition, right?
Any condition. And we know that, certainly if your blood sugars, either acutely, that day from time to time, or your hemoglobin A1C, which is a longer evaluation of your blood sugars, if that's higher, that is certainly going to put you at further risk of complications, really of any disease or complication, including COVID.
And Matt, I bet that's really true for the operating room too, right? People whose diabetes is out of control, A1Cs are higher, they're just not going to do as well.
In the cardiac surgical population, you sort of rarely find someone who doesn't have diabetes, to be honest. It's not to be a little bit facetious, but it's definitely a disease entity that goes hand in hand with cardiovascular disease. It also speaks to the point that you still have to be vigilant for your signs of chest discomfort, shortness of breath, these kind of things during a pandemic, because not every illness that occurs is COVID during this period of time. So I would still be hyper vigilant as a diabetic for my signs of other cardiovascular problems.
All right, one more question.
All right, Brett says we talk a lot about the death toll with COVID. He's curious, what is the death toll with heart disease and heart failure? How does it compare to the death rate with COVID?
Oh, that's another. We've had some great questions today. People are listening. They have tuned in and listened. Yeah. Matt, talk to us a little bit. What do you think how does the death toll? I'm trying to say it myself. This is actually a hard question to answer because it's sort of nuanced, but because people can have heart failure for many, many years before they pass away. So try and help us with that a little bit.
Me or Nick?
Matt, well, I'm going to come to both of you. I should have said Nick.
Go ahead, Nick.
I said Matt and looked at Nick.
You're the smart guy. I still want to circle.
Go ahead, Nick. Well, he's a medical guy. That's why he's so smart.
Yeah. No, that's a very nuanced question. I agree. I think heart failure is very tricky in total because many patients have chronic problems with heart failure, and we see a general progression of heart failure over time, and with progression of symptoms and need for different therapies, whether they're surgical or medical or device related. And then there's also a group who just obtains or gets heart failure acutely. And that's probably a slightly different group in terms of some of the lack of chronicity that heart failure can have on other organ systems. So I can't comment specifically on COVID and heart failure from that standpoint. I'm not aware of any literature that looks directly at that.
All right, Matt, any other thoughts?
Yeah, I mean, we have Dr. Hagman and I have a very skewed sort of patient population. So we know that the numbers of people who have advanced heart failure, the overall survival at 1 or 2 years once you reach a certain point is fairly abysmal. Meaning, some at 2 years measured in single digits if you're on medicines to keep your heart pumping and these kind of interventions. And then there's the chronic person who has coronary disease whose mortality is 1% when you go for surgery. So it's a difficult question to answer. I think the chronicity of people's problems influences their long-term survival. So someone who's had heart failure for 20 years and now is at the end and needing to make very significant decisions about what next steps are, that mortality would be far higher than what COVID's would be on an annualized basis. Yeah. I think it's like a lot of things when I talk to patients, it's, a lot of the things that we interact with people with for surgical heart disease anyways is you've got a, 50% chance of not doing well if we don't operate on you, and you have a couple of percent risk of bad things happening. The problem is nobody dies 1% or 2%, right? So a lot of the bad outcomes from cardiovascular disease are unfortunately all or nothing events. So measuring the actual mortality rate of a certain entity, it's all sort of retrospective looking at, the population. So we know for transplant patients, our goal and what the metrics are is 90+% survival at 1 year. So these are the numbers that we're sort of relating for transplant patients. And I think that would be, far more of a mortality rate than people who, or the sort of rate in the community of people succumbing to COVID-19.
Yeah, it's an interesting question too. So just as a thought, Nick, what percentage of patients who have a heart attack and come into the hospital pass away?
I think in total it's very, very low.
Right. And how many patients do you have who pass away who have to have heart surgery, Matt?
I mean,
from acutely in the hospital.
Acutely in the hospital, it's around 1%, 1 to 2%. Yeah. I quote, it depends on the entity, right? Some of, if you have a type A dissection, then the numbers are 19% for surgical mortality. But
heart failure or heart attack.
Failure, yeah. Lower. I mean, as a credit to the heart failure program here, and Dr. Sauer and Dr. Abick, the outcomes for this institution from things like LVAD and heart transplant are among the best in the country. So
just to put in perspective, if yours are less than 1% or whatever, a heart attack 1%, if you come in the hospital with COVID-19, in our hospital, your chance of dying is 9%. And if you end up in the ICU, it's about 30 or 40%. So COVID is real. It is really bad. No, you're not.
I'm just saying that the overall population.
No, you didn't at all. I'm saying this to our listening audience. COVID is real. It is not influenza. Yeah. We have that question a lot, Dana. And we just have to be, I think, honest about that.
Yeah, I mean, just from the number of deaths from March until now, in that short time span compared to a full year of influenza, obviously, influenza is not COVID and COVID is not influenza. To your point, it is apples and oranges. This is an infectious disease and you're comparing it with this chronic or acute situation with your heart. But if you look at other infectious diseases around the world too, tuberculosis still has a very high death rate every year around the world. Malaria still causes a lot of mortality around the world. So it's very difficult to compare heart disease to COVID-19. They are separate entities, but both are you don't want either one.
And the problem with COVID-19 is it's so darn respirable. Well, as we wrap up the show, let me first go to Matt and to Nick, and then we're going to go to Carol for just a minute, because we're talking a little Star Trek with Carol. Go ahead. Final thoughts.
It's really nice to be involved with a story like this, and I really am grateful for getting to know you, Carol. I really am. I thought it was excellent. The program here is exceptional. I'm glad that we were able to help in this way.
Nick?
It's been such a pleasure taking care of Carol and working with her through this process. She's such a strong woman and has such a caring sense about not just who she comes into contact with from a transplant standpoint, but just her life. It's been an incredible. It's been excellent to get the insight into learning more about her, and that's what keeps us going as docs.
You bet. Carol, final thoughts for today. And by the way, I still love that comment, finding joy in every moment of the day.
Yeah.
I just want to say that if you have had a chronic condition for a long time and something doesn't feel right, you know your body well enough that you should go see your medical profession and address the issue, and just be very appreciative. I'm very appreciative of having the kind of care that I did. And like I said, I didn't realize how ill my heart was. And I'm just so grateful every day that I've been given this new lease on life so that I can continue on my journey.
And a great journey, and congratulations. And again, I just love the Star Trek characters behind you. Live long and prosper. That's what my wife would say. Oh, that's for my husband. Right. That's right. Dana, final thoughts?
Yeah, I think these were very insightful questions today. I know tomorrow we will be able to answer some of those questions. The testing question is a very good question. We would certainly, again, we would like testing for everybody every day with a good turnaround time. We don't have that yet. As we move further into this, we are just in the infancy or toddler period about what we know about this disease, and also all of the processes that we have, including testing. We will get to be able to do more and have a better picture on where we can go from here. Overall, it looks like the 7-day running average in the Kansas City area is going down, which is very good. It's still very high, but I think people continue to wear your masks, don't gather in large groups, and stay physical distance, and hopefully we can get this the overall number of cases in the Kansas City community down even further.
Well, I think this has been a great program, great session today, and so appreciate everybody who's been here. And the questions are hard. We're going to have to go study a little more. Tomorrow, we bring back Chancellor Dr. Doug Girard, who's going to help talk about the reopening at the University of Kansas. They went back to school yesterday. Chris Wilson is our VP of Systems Innovation and Integration. Will also be on the program. Chris has been helping spearhead our aid to the University of Kansas and are working with KU, and specifically in the area about testing and results. And what does that mean? What does it mean to the community of Lawrence? And what do we think that means across the country as a microcosm of school and university reopening everywhere? Hey, just also a reminder to go to Church of the Resurrection if you can today to donate blood out in Leawood. It's safe. Your blood donation is needed. We talked about organ donation, but in many ways blood, oh my gosh, you can do such great work with that. SaveALifeNow.org is the place to sign up. Please give if you can. Hey, a couple cool pictures too. Sean sent us this picture of dropping his son off at St. Louis University. I know when I dropped my kids off, I cried the entire way home on each one. I was 3 for 3. Christy sent in a picture of social distancing during a faculty retreat for St. James Academy. I like that. Being in the woods is still the best way to be distanced. I love that one. And then weekend fun at the Topeka Civic Center. Every other table blocked, people trying to distance. Love the Hamilton shirt. That's the best. In the room where it happens, right there. And finally, this Cows mascot. Cows, by the way, COVID weariness syndrome. We all have it to some degree. This Cows mascot was sent by a viewer who says she appreciates the work of the health system and providing information throughout this update. Keep sending those pictures. Those are the best. And yes, Cows is real. One of the challenges during a pandemic, I think, is to find joy and to find a little peace. And I just treasure every moment we're each able to do that. And one of our goals on this program is to show that amidst some of the hardships, there is still hope and there is still joy. Carol, thank you for being on the program today to help share your hope and joy and to know that it's still out there and that miracles do indeed happen.
Thank you.
The response to live long and prosper, if you're a true Trekkie, is peace and long life. To all of our listening audience, we wish you all the above. We'll be here tomorrow, and remember, until then, there's still no place like home. Thank you.